computer. There you go. Now we can start the video. So first of all, can I just get one of you guys to let me know? Can you see my screen, my presentation?
Yes.
I can
Perfect.
see you. Yes.
Perfect. Thank you guys. Okay, guys. So today we're going to talk about, in general, DNA viruses. So, DNA viruses, what do they go into? What are they? Well, very simple. They're viruses that have their genetic material consisting of DNA. They're one of the most diverse groups of viruses, and you really can put them into these kind of three categories. So first of all, you can divide them into either icosahedral shaped or helical slash complex kind of shaped. So the icosahedral, they can be both naked and enveloped. The naked are the adenoviruses. These are the most common viruses that you get usually when you have, let's say, a common cold of these sorts. We're not going to talk about a lot of adenoviruses or maybe in respiratory viruses we might speak about them, but not today. But we're going to be talking a lot about the enveloped ones, which is your herpes viruses. These are, I'm quite sure the most well-known viruses to you guys. You've definitely heard a lot about them. But we're definitely going to be diving quite a lot into herpes viridae family. And we're going to also talk, just scratch the surface about pox viridae, because pox viridae is one of the most, let's say, weird viruses, one of the biggest viruses you'll ever see, and have a lot of kind of, let's say, kind of exceptions in virology, to which we'll talk a lot about today. So when it comes to, let's say, the herpes viruses, we all know these. These are the herpes simplex viruses, the varicella zoster viruses that causes chickenpox when we were like, quite small. These could be basically as well these other, let's say, cytomegaloviruses, Epstein viruses, which really are gonna talk in general. But the nice thing about DNA viruses that makes them very, let's say, kind of clinically interesting, they usually give us a lot of skin lesions. So, for example, we know with herpes simplex viruses or the varicella zoster viruses, we always get vesicles. These really annoying filled-like vesicles all around our body when we get infected by them. But when we get pox viruses, for example, like one of the examples is molluscum contagiosum, we get these fleshy papules, which I'll show you some pictures about. These, again, skin lesions. Of course, we know papillomaviruses also are within these DNA viruses, which I'll be talking about. These can cause papillomas or warts. Very, fleshy-like, very kind of almost look like small little cactuses in our basically fingers. Look very disgusting, and we'll definitely talk about them. But of course, some other DNA viruses, I call these more, let's say, the silent killers. These guys usually, when they infect us, they might do a bit of, symptoms, but then they rely dormant, and they really can be dormant for years and years and years until they actually come up and try to kill us. So we'll definitely go into all these the different differences among them. But right now, I just want to just, talk in general about DNA viruses because because their genetic material is DNA. You have this concept that their replication happens in the nucleus purely because the replication, kind of the host proteins for replication for DNA, is found in the nucleus. So the viruses need to find a way to get inside the nucleus to start stealing the host, the kind of replication machinery to start, multiplying their own genomes. Among the DNA viruses, you have two kinds, basically the ones that have a linear double-stranded genome and the other ones that are basically more circular. So the linear double-stranded genomes basically are the herpes viruses, for example. Then so the circular ones are technically, I think if I'm not mistaken, are more the human papilloma viruses per se. But one thing, of course, as I said, most of these viruses are doing basically, replicating in the nucleus. There's only one exception. One exception of a virus that does not replicate in the nucleus, even though it has a DNA genome, and that's the pox virus. The pox virus is among the unique DNA viruses that does not do that. That's purely because pox viruses have their own transcriptional enzymes. So it doesn't need the host's own machinery. It just needs its own, it has its own, so it can do its replication in the cytoplasm. So that's why pox viruses are always considered as one of the most annoying ones in general. So today, I want to really, really go into much more depth with herpes viruses, and we'll definitely gonna be talking about it. When it comes to herpes viruses, it's a family. There's many different types. You have your herpes simplex virus type 1 and type 2, your varicella zoster virus, your cytomegaloviruses, your Epstein-Barr virus, your human herpes 8, which we call the Kaposi sarcoma associated viruses. These are, quite well known. These have all of these herpes viruses have a DNA genome, but it's linear. It's a linear double DNA strand. And one thing that is very characteristic of them is their ability to create latency, a lifelong latency. And what does that mean? They're able to insert, first of all, their genome into our genome. That's one. Two, they're able also to basically remain dormant and go into this latent phase in where they stop their viral replication. And this could be stopped for days, weeks, months, years, or decades. So the time can really differentiate, like be different among people. And then suddenly they get reactivated. They start again producing viral symptoms. So let's imagine you have an infection, the primary one, you have your symptoms. The virus basically inserts its genome into your genome and remains dormant and latent. So it's not producing any viral particles. You have zero symptoms. You don't even know that are infected. Suddenly, this virus gets reactivated. You start producing quite a lot of virions, and now you get symptoms again. And this can keep going on and on and on and on. So the structure of the herpes viruses, they're quite big. They're between 100 and 200 nanometers in diameter. So, and generally for a virus, that's generally quite big. It actually puts them in almost the second biggest virus that are infecting humans. The first one is pox viruses. Pox viruses are among the largest viruses that can infect a human. They basically, as I said at the beginning, herpes viruses have a icosahedral capsid, as we know, but they also have a nice envelope. So here the C stands for the capsid and the E stands for the envelope. But one thing that is super interesting in these viruses, so this is a very nice electron microscope image. You see this kind of zone over here that's between your envelope and your capsid. This zone is filled with proteins, specifically these tegument proteins. These tegument proteins are extremely important in facilitating viral replication, but also influencing transcription and translation. We're definitely going to talk about them a bit more in details a bit later, but in between the envelope and the capsid, you have all these proteins, these tegument proteins, which are super important in making these viruses, let's say, more multiply and, kind of regulate its transcription throughout its infection course. And one also interesting thing is that the envelope that these viruses have, they've stolen it from the host's nucleus. So as we know, they go inside the nucleus, they start replicating inside the nucleus, and once they're ready to go, what they literally do is they literally kind of butt off from the nucleus, stealing basically its membrane. So when it comes to replication characteristics of herpes viruses, as we know, they love to go into the nucleus. But one thing that they basically in general herpes virus love to do is do these inclusion bodies. We've spoken about these inclusion bodies. These inclusion bodies are literally these massive, literally kind of bodies of protein and viruses. This is like sites of where you have a lot of viral protein and virins being replicated all together. And you usually see them within the nucleus. So this is your cell. You can clearly see this is the nucleus, and you see this massive body, very dark body. And this usually can be very helpful for us in the clinic. So what can we can do? Let's imagine we're suspecting someone of being infected with a virus. We can take a bit of a scrape of cells or something. We can look at it under a microscope, and we can see if we start seeing these very big, let's say, inclusion bodies within a nucleus. This is already kind of indicative that, hey, this is a herpes virus because these are the only ones that usually can cause these kind of stuff. Usually, pox viruses also do that. They also kind of have this, but these pox viruses, they do it more in the cytoplasm. Because again, their site of replication occurs within the cytoplasm. So this is very nice characteristic and clinical differentiation among these viruses that you can actually have a look. And as I said, herpes viruses go into latency. So once they basically infect, they can insert their genome into your host genome, into the host genome, and it can stay there. And you basically have minimal to zero viral replication. So the virus is not replicating at all. It's not doing any translation or transcription of its genome at all, technically. And this is what we call the latency phase. So if you want to measure the amount of viruses, it's literally close to zero. But then suddenly we have an environmental stress or stimuli, be it sunlight, be it stress, be it UV, so many different things that it could be. Suddenly this virus wakes up and we start to getting a reactivation and we suddenly have to, or we get to see these DNA viruses really just going all overboard. They start to replicate like crazy and start producing quite a lot of viruses, which then basically can cause more symptoms. So this is basically, we'll definitely be talking about how every single one of these herpes viruses are able to do this. The mechanism of latency, it's not so 100% understood. It's quite complex, but we know quite in details how herpes simplex viruses and cytomegaloviruses do that. So herpes simplex viruses, what they do is they create something called latency associated transcripts, LATs. And what LAT is are literally, as the name says, is a transcript that produces microRNAs. So I'm quite sure you guys know what microRNAs are. These are small little mRNAs that literally they inhibit mRNAs. They literally kind of turn on machinery within our cell to destroy certain mRNA transcripts. So they literally produce these transcripts that what they're doing is shutting down viral mRNAs from being translated. That's what they do. So something happens in a sense, specifically within the virus. They have basically this heterochromatin. So technically this, they have their own, let's say, genome that has in some way these histones. And something happens if they open up and the LATs start to increase, which then basically what they do is start producing microRNAs to stop. And that's how basically the herpes simplex virus is able to keep this zero viral replication. CMV also does very similar kind of thing. They use also microRNAs to kind of stop viral mRNAs from transcribing or translating, sorry. So again, similar kind of mechanisms. But CMV, one thing that also CMV does quite well, it inhibits the cell to go into apoptosis and it keeps it surviving. And this is important because imagine you have a CMV that now is basically forming a latent infection. So it's there and staying there for quite good time. If the cell dies, well, the CMV genome also gets cleared out. So for its own good, it wants that cell to still be alive. Because if it's alive, it will still be able to, do its job. So CMV has a lot of these different types of machinery to keep or it kind of inhibit apoptosis in general. And then you have basically when you have this latency where you basically have zero viral replication, suddenly, as we just said, a stress can reactivate them. Again, this stress can be many different things. In herpes simplex viruses, we know that these stress can be sunlight, fever, stress, or trauma. How do these basically, triggers induce reactivation? Again, is not known. It's really, really not known. And what happens is that the virus resumes its replication and can lead to technically symptoms again. And you go on this loop of latency and lytic infection and back again, on and on and on for the rest of your life. So when it comes to herpes viruses, as I said at the beginning, it's a family. There basically are around 8 different types of let's say, human herpes viruses. Basically, these are the names. I actually never knew this existed until my brother, like he's a doctor. This is more clinical. That apparently in the clinic they do call them by either, oh, it's a human herpes 4 or 3 or 2. Honestly, in the lab, we don't call them like that. We call them by their common name or by their subfamily. So for me, I don't want you guys to know the virus name, the names, the human ones. I don't need this. I need you guys to know the common name and the subfamily because the subfamily really determines the disease pattern, but also more importantly, the tissue tropism. Because we have your alpha, basically herpes viruses. These are your herpes simplex type 1, your type 2, and your varicella zoster virus. These guys, they love to infect epithelial cells, but they love to do or establish latency in neurons. So they have this specific, let's say, tropism to go into neurons and establish latency there. So if I say alpha subfamily, think about herpes viruses that love to go to neurons to do latency. Then you have basically your beta herpes viruses. This is your cytomegalovirus. Cytomegalovirus is a weird one because it loves to basically, infect a wide range of tissues and latency in any different type of cell. So beta, let's say, herpes viruses, they love in general to go everywhere. Their tissue tropism is quite broad. And then you have the last one, which is the gamma. So these are your Epstein-Barr viruses and the Kaposi sarcoma. These guys, they love in generally to infect and produce latency on your lymphoid cells. These could be your B cells, your T cells, your NK cells. They just love to go more into lymphoid cells. And they're very associated with malignancies. Epstein-Barr virus can cause many different types of cancers, along with your Kaposi sarcoma associated virus. The Kaposi sarcoma associated virus, its name says it, it's associated with sarcoma. It's a specific type of tissue that gets basically, oncogenic. As I said, also just at the beginning, you have basically your gamma viruses or your gamma herpes viruses that they love to induce cancer. Could be your Epstein-Barr virus, your Kaposi sarcoma viruses, these ones in general, and they're linked to producing many different types of viruses, specifically EBV, so your Epstein-Barr virus. Your Epstein-Barr virus can induce Burkitt's lymphoma. Burkitt's lymphoma is a B cell malignancy because again, Epstein-Barr viruses loves to infect lymphoid and specifically B cells. And what they do, specifically Epstein-Barr viruses and also this Kaposi sarcoma linked virus, once they infect, they can stop apoptosis and they can induce other survival signaling. So they're messing up with the cell's own ability to kill itself or regulate itself. So that's why we get a lot of different basically cancers. So in general, when we suspect someone of, let's say, if you go and you want to do some clinical testing to see, hey, how susceptible am I for a cancer? A lot of clinicians will ask or will try to see how much viral titer of Epstein-Barr virus do you have, or the Kaposi sarcoma virus, because again, these viruses, they once you get infected with them, they stay there. Of course, it's not that if you're infected by them, you're gonna get cancer. No, there's a chance of you getting cancer. So what doctors can do is they start seeing how active is this virus. If this virus is quite active, then they'll be like, okay, we do suspect that you might be getting cancer at some point or something. So now this is more, let's say, the specifics about herpes viruses. Let's go into the details of them. And let's start with, your most common type of herpes viruses that we get infected with, which is your herpes simplex viruses, HSV1 and HSV2. So HSV1 and HSV2 are extremely closely related. So structurally and genetically, they're identical almost. Almost. They have very small differences, and these differences come in antigenicity. So what that means is that they have different amino acid compositions in their proteins, specifically the ones that are in their surface. So it's literally these small little differences between them. But through a microscope, it's impossible to really distinguish them because they look so similar to each other. The only difference, as you can see here, are the proteins from the outside. Literally, that's really the small little differences that they have. But one thing that we technically get to see, you see herpes viruses, what when they infect, they usually prefer to infect anything above the waist, and specifically your oral and your facial regions. HSV2 is below your waist, and particularly your genital areas. But this is not a, let's say, a strict rule. It's not that if you have an infection in your face, it means it's 100% HSV1. That is not true. It can be HSV2 as well. So, what we see specifically with human behavior, there's been a lot of oral and genital contacts between humans. And what we've seen is HSV1 has been jumping from your, let's say, your oral cavity into genitals and vice versa. Genitals, HSV2 jumping into your oral cavity. So it's not a 100% rule. In general, HSV1 is prefers the oral kind of routes, HSV2 more genital. But again, they can be found in both. So again, as we know, as I just said, structurally and biologically, HSV1 and 2 are indistinguishable. So again, under a microscope, you're not going to be able to really say the difference. It's only these very small differences of that you see in the host and basically in its receptors or it's in its proteins that are on the outside that are differently. There's small little differences, and these small differences can actually cause them to have different tropisms. So why HSV1 likes to go more in the oral, facial kind of, let's say, kind of cavities, while why HSV2 likes to go more into your genital areas. Because, of course, these proteins that are outside, these are the ones that dictate, per se, where they infect, basically what host cells they're going to infect in that kind of sense. So when it comes to the initial steps of herpes virus infection, it always starts with basically one of the proteins of the herpes simplex viruses, and specifically this glycoprotein. These glycoproteins, what they first do is they bind to heparin. This heparin sulfate is quite found in almost every single type of epithelial cell. They bind to that, but this is basically not so specific because again, it's found everywhere. But this binding first allows, so this is the initial attachment, it allows basically your other glycoproteins in your simplex virus to bind to a more specific receptor, this host receptor called nectin. So once it binds to nectin, which is shown here in blue, this is going to really help quite a lot your herpes simplex virus to fuse its membrane with the host membrane. So it's two attachments. First, you have heparin sulfate attaching, and then you have the nectin. And this then basically helps with the fusion of membranes, which then allows technically the capsid of the virus to be released inside of your host cell. Once inside your host cell, it starts to basically make its way towards the nucleus. So let's imagine it's actually infecting a neuron. It's gonna first, of course, through nectin and heparin sulfate, it's gonna bind, it's gonna release its capsid, and specifically its whole capsid with all these tegument proteins. Because remember, between the membrane and the capsid, there's these tegument proteins. So these, let's say, capsid and tegument proteins are transported using this dynein, so these microtubule motors. They transported all the way towards the nucleus. When inside the nucleus, sorry, when it's basically very close to the nucleus, so you can see here, the virus is going to suddenly destroy its capsid and it's going to release its viral genome, so its DNA genome, and the DNA genome is going to go inside the nucleus. And there, it now finally can basically do its job. is basically in the nucleus. But of course, with not just the DNA that is actually put, a lot of tegument proteins, specifically VP16, are literally thrown into the nucleus. So what are these tegument proteins? What are they doing? Well, for example, VP16, which is an example of a tegument protein, what it technically does, it's going to basically start the transcription and expression of the DNA, of the viral DNA. So VP16 has a very crucial, let's say, job in starting viral transcription. So VP16 is going to start the expression of these immediate early genes. What are these immediate early genes? These are five other genes or five other proteins that have regulatory functions. So the expression of immediate early genes, it doesn't need prior transcription. It doesn't need that the virus is basically replicating or basically creating proteins. No, because the VP16 is already there. The VP16, once it's in the nucleus, it does its job and it starts, expressing these immediate early genes. So you have these regulatory functions, these regulatory proteins. These regulatory proteins are now going to start the transcription and translation of your early genes, which are around 25. These are all DNA synthesis, all nucleotide metabolism. These are all enzymes and proteins needed for transcription, translation, and DNA replication. These are all basically then, done. These, what they do is they start and they literally start pushing to the transcription and translation of your late genes. These late genes are now your structural components. So these structural components are technically the proteins needed for creating your capsid. So what we see with herpes viruses and in generally with almost every virus, we see these segments of genes being transcribed. You don't get them. This is not happening all at the same time. They go in phases. So VP16 starts this. So that's why we need tegument proteins. Tegument proteins initiates all of this because immediate early genes and the early ones and the late ones, they all require that transcription and translation occurs first. So, sorry, the early and late. The immediate early, not really, because you have the VP16 that is pushing this, and this then allows for this to happen, to allows this to happen. So you need already proteins already there to start. So that's what tegument proteins are there to do. Once the virus transcribes, it translates, it duplicates its genome, it's creating its now capsids and everything, it's literally going to steal a bit of the membrane from the nucleus. So it's going to butt off, it's going to steal a bit of the membrane, and now it's going to be nice and enveloped. And now it's going to leave. This is not the best picture, it was the best one I could find, but technically, when it leaves also with the nuclear membrane. But this leaving the nucleus and leaving the whole cell is very smooth in a way that the cell doesn't die. And if you think about it, it's very important that the cell doesn't die because the virus is there doing its latency. It doesn't want to die. It doesn't want this basically cell to die. It wants it to stay alive because if it's still alive, it can still basically, still be in its latency form. So that's why it's very nice and smooth, this exit. And of course, they start spreading to your neighboring cells. So one thing, as we said, the herpes simplex viruses, usually we are able to get them through contact. So first of all, they really infect. Oops, sorry, I have a question. Will it exit with its envelope? Yes, Ryan. It will actually exit with its envelope. So this is why this is not the most correct picture. It does exit with its envelope. It needs its envelope. So when we get infected with HSV, which is usually through skin contact, the first thing, of course, that the HSV do is they love to infect epithelial cells. But of course, once they infect epithelial cells, they start doing a lot of destruction and a lot of killing. What they're going to do, they're going to start moving until they hit a neuron. Because again, herpes simplex viruses, they love establishing their latency in a neuron. So they're going to go to a neuron, and specifically, you see they love to go to sensory ganglias. So HSV1, they love to basically go to this trigeminal ganglias, and HSV2 to more to the sacral ganglias. So again, it's this glycoproteins that they differ that makes them have this specific tropism towards a specific ganglia. So once they hit a ganglia, they enter and they start basically again, you have these nice microtubule motors like dynein that transports the capsid along with literally your tegument proteins, and they start going from your axon terminals, which are these little things over here, and they keep moving all the way towards the body. So this is where the nucleus is. So this transport from the axon towards the body of a neuron is called this retrograde transport. So it's literally moving towards the nucleus. So it's retrograde transport. And of course, it then establishes latency there. It goes there, it puts its genome, and it doesn't do anything. No viral replication, everything is shut. When we have a reactivation, you have production of a lot of viral capsids, a lot of virions. They're again transported all the way from your nucleus all the way to literally your axon. So this is called antegrade transport. So from the nucleus to the axon, and they start to basically infect neighboring cells. So more specifically, they start to go more into your epithelial cells to create, symptoms. So, what are the clinical manifestations of herpes simplex viruses? I'm quite sure you could definitely have seen basically some pictures or people having this. It's very, very common. You have these, let's say, vesicles that are forming. So, this is in your mouth, and these are all over basically the genitals. So, as we said, herpes simplex 1, it loves to go mostly on the mouth. Herpes simplex 2 loves more the genitals. But again, you get to see them also basically, you can see herpes simplex 2 on the mouth and herpes simplex 1 on the genitals as well. So usually these are localized. They just stay there. If you are immunocompromised or if you're a baby and where your immune system is not really doing the best, they start to disseminate. They can affect multiple organs, and there is where it can be dangerous. But if you're healthy, young adult, that has a good intact immune system, there's nothing to worry about because they just come up and that's it. And in generally, these vesicles that they create are very characteristic. Clinically, you directly know that this is herpes simplex virus because they have a very nice progression. Well, nice. They have a very basically very, certain succession that happens. So first of all, the first thing that happens, you have this erythematosus area. So you have this literally bed of redness. So which I'm pointing out right now with the mouse. So this is called a erythematosus bed. Within this bed, you start to create vesicles. So these are your vesicles. These are literally these kind of sacs filled with a lot of fluid. And all that fluid is literally virus. It's a lot of viruses in there. So they're extremely contagious. Suddenly that literally kind of fluid, kind of sac explodes, and it literally starts in some sort of way to crust. So it literally breaks, it crusts, and then basically when it crusts, it starts to bit by bit ulcerate and literally heal. So again, when you start seeing a patient having erythematosus beds, then later on you have these vesicles. These vesicles are now getting water. They're literally kind of in some sort of way exploding. They're rupturing. They're ulcerating and crusting. Literally, if you see the sequence, it is very it's a big hallmark of herpes simplex viruses. So it's in generally quite indicative. Doctors usually when they see it, they're like, okay, you have the herpes simplex virus. So primary versus recurrent infections. So the first time the primary infection of HSV, we refer to this as the first ever time that you get infected with the herpes simplex virus. And specifically at this time, you do not have any pre-existing immunity. You do not have memory B cells. You don't have memory T cells that are helping you to basically kill it. So it's the first time you've ever encountered this virus. And usually, the first time you get infected, it's the worst because you actually have quite a lot of symptoms and they're quite annoying and they take quite a long time to actually resolve. Can our immune system control HSV? Are both innate and adaptive immune responses? That's a very good question, Luna, and we'll definitely go that into more details about this. I think it's literally in my next slides. Yes, it's there. So if I go back into here, but I'll definitely go back into that, Luna. Just give me 5 minutes for that. So in the primary, because we don't have an immune response, they really take they can do a lot of damage and can take quite a long time. Then they go into latency, and then reactivation starts to occur. When reactivation occurs, now we do have a B cell memory. Now we have a T cell memory. So symptoms are not as bad as our first time we got infected. Actually, we have less blisters, and it takes, rather than 2 weeks, it might take 1 week or less for it to really leave. So this is where we see our immune system actually is able to control it in some sort of sense. So as I said, basically HSV1 is more the oral labial disease. It really goes mostly in your mouth. It's present in your basically in your gingivitis, more basically in this kind of basic in your mouth, you and you're basically in the gums. So you really get these very kind of fluid-like blisters all over the mouth or in your gums. And again, as we said, it loves to establish latency in the trigeminal ganglias. So once it goes into latency there, it stays there for the rest of your life. So basically, they're not able to be removed. And people have this misconception that if you have symptoms, you have HSV. No. By the age of 50 or 55, I think, 80 to 90% of people have herpes simplex virus. Either one or two, most specifically one. Because it's epidemiology is is the biggest. It's not that if you have herpes simplex virus, you're gonna get symptoms. It's actually the contrary. Most likely you will not get symptoms. 80% of people that are infected with herpes simplex virus 1 do not get symptoms. It's only 20%. Don't ask me why. I really don't know what why is that. So I'm almost 100% sure that the 80, 90% is hidden on 100%. I'm quite sure that by that one point, all of us are going to basically will have the herpes simplex virus 1. So there's a big stigma with herpes simplex virus 1, which I never understood why. That people were like, oh, you deserve having herpes simplex 1 because you kissed someone with herpes simplex 1. No, it's the literally one of the most common viruses you'll ever get in your life. And almost all of us have it without even having symptoms. So keep that in mind. Herpes simplex 2 is much more, a bit more different. You basically have them basically, in your genitals because it's usually more sexually transmitted. So that's where you basically get them in your genitals, basically. So again, they establish latency in your sacral ganglias. So, in generally, as I said at the beginning, herpes simplex viruses are very localized. They don't do any harm. They're quite harmless. You have these blisters that come up maybe once a month, once every 3, 4 months, or once a year. So, very easily manageable to live with. Where it can get very dangerous is for babies. So there has been huge scandals around the world, and as we know, there's this thing of people agreeing and not agreeing about kissing babies in the mouth. There's this huge one. So I don't know if anyone here watches NFL. The most famous, basically, kind of quarterback, Tom Brady, went into this, for example. He basically was shown in a video to be kissing I think, his daughters or one of his baby in the mouth. In some cultures, it's a normal practice. And generally, I have no issue with it, but when it comes to medically, there's an issue to this. Because if you have herpes, and as I said at the beginning, you could be basically having herpes without you even knowing, and an active form. So you don't really know. It's not that if you have symptoms, it means that you're going to have herpes. No, that's not true. You can pass these herpes from the mouth, from your mouth to the mouth of the baby. And because the baby does not have a proper immune response, it's going to develop quite a severe infection towards it. Because now the herpes virus is not, it's B cells or T cells are not able to control it. So it's going everywhere. And it disseminates to technically not just the skin, to the mouth. It can go all over your eyes, to basically to your forehead, but more dangerously to your central nervous system and internal organs. And specifically, it can induce encephalitis. So it can really go literally into the brain to cause an inflammation there. And that is extremely dangerous because you can have fevers, headaches, confusions, seizures, and altered consciousness. So it can be very dangerous in that kind of sense. Of course, this is not less limited to encephalitis. You can go inside to the organs and kill them. And then usually this encephalitis is mostly caused by HSV1 because again, when it comes to HSV1, it's usually the one that's more in the mouth. So going to Luna's question, which was the immune responses, yes, it's your immune response really does stop your herpes simplex virus. It really stops them from disseminating to other organs and makes sure that they're very localized. That they're just in the mouth or within basically a certain confined area. And the T cells are extremely important for that. They're very important, along with also antibodies. So that's why what we see in general that people that are immunocompromised or babies that do not have a proper immune response, they do have much worse symptoms and they have actually can lead to death. But of course, can this cure you? No, because again, HSV love to evade your immune system. And it can evade it for quite a long time. Basically, it can evade it by snatching the MHC complex. So now T cells are not able to recognize it. They can also interfere with apoptosis. It stops the cell from dying, so that's a way to evade. And also remember, HSV love to create these multinucleated cells. They love to bring cells together, so they do not need to go outside and be caught by B cells. And they love to form latency in neurons. The immune system will not kill a neuron because we cannot spare. If we kill a neuron, we're screwed. So that's why they will never basically, we're not able to clear them out. So the transmission epidemiology, as I said, transmission through HSV usually is through direct contact, through infected secretions or lesions. So HSV1 is through basically non-sexual contact. So this can happen through childhood. HSV2 is usually through sexual activities in general. And as I said, you have a lot of asymptomatic symptoms. So you can be completely symptomless and keep shedding the virus and keep giving it to people. This is why by the age of 50 and 55, everyone is going to be infected by it almost because you don't know that you have it. And you're out there basically, passing on the virus without you knowing per se. So sometimes it's very important to, understand these dynamics because you can start, creating prevention strategies like, telling people, please do not kiss your newborn at 6 months year old. If you really want to do that, go later on, but not at 6 months because it still doesn't have a proper immune system. This can also be having safe sexual practices. If you're suspecting you're having HSV2, wear a condom. These kind of things that can really help decrease the transmission. So when it comes to diagnosis of HSV, in general, as I said before, HSV, they love to create these multinucleated cells. So what you can do is you can do a Tsasnak smear. So you take a bit of the lesions where you see a bit of basically, let's say, these vesicles. You take a smear, you look at the cells, and if you start to see this massive multinucleated giant cells, this is indicative of herpes. Herpes viruses love to do this. But of course, this doesn't tell you if this is the herpes simplex 1, herpes simplex 2, Or this could be also the zoster virus. Varicella zoster virus, which I'm going to talk in a bit about, can also cause this. So it's not a definitive kind of test. If you want to be more definitive, PCR. So you go, you take a bit of the fluid and you literally start looking for viral DNA. So this is super standardized. Literally every hospital has a standard procedure that they follow. This can tell you, hey, is this actually herpes or is this basically zoster virus? Is this type 1 or type 2 of the herpes simplex virus? So it's very important. And also, PCR is much more sensitive compared to a Tasnac smear. Tasnac smear only you can only see these multinucleated cells when you have a lot of virus. PCR, not really. You don't need a lot of copies per se. So antiviral treatments, the treatment of herpes simplex virus, generally, you're not able to cure it, but you're able to technically, stop its symptoms. And usually that's happening when they're quite active in replication. So we use acyclovir. I'm not going to go into this because on Tuesday I spoke about acyclovir. So it's a nucleoside analog that we spoke about. So now let's go into our herpes zoster virus. So herpes zoster is very, very cool. It's a very genetically and structurally very similar virus to your herpes simplex viruses. They look literally identical. They have this linear double-stranded DNA genome, and it loves to replicate in infected, basically, in the nucleus of infected cells. So very, very similar. The first time you get infected with the herpes simplex virus, sorry, the zoster virus, you get varicella, chickenpox. We know this. We get this. All of us get this throughout our lifetime. What is this varicella or this chickenpox? Well, these are you get what happens with basically this herpes simplex virus. We usually get it through our respiratory tract. It spreads to our bloodstream, specifically then to the skin. And you have again these very similar vesicle filled kind of what do you call it vesicles all around our body, and you get this successive crops. What does that mean? You start to see these lesions, these literally vesicles, at different stages of development simultaneously. So you, for example, you see these very small little kind of vesicles that are, growing, while you have these other big ones that are already crusting. So this is what we mean by successive crops. Very, uh, you know, very easily for a doctor to actually see, okay, you have the varicella chickenpox. It's very easily visually seen. Usually in children, as we know, varicella or chickenpox is, very mild. We get it for a week or two and that's it. We stay at home. We don't want because it's very contagious, so we don't want to contagious people. But it can be very severe in adults and immunocompromised individuals. And I'll talk about this a bit later. So the varicella zoster virus, once it infects, it literally goes again to other sensory nerve ganglias and they establish latency. But the latency here can be literally years or decades later that they reactivate. So it's not 100% like almost all of us have this herpes zoster virus, but not all of us gets a reactivation. It's only a specific few that we get this actual reactivation. And this reactivation leads to something that we call herpes zoster or shingles. And it's literally this vesicles that we see, but they're literally confined to a certain area. It's not all over our body, but it's confined to a certain area. Where or how it's confined to a certain area, it depends on what sensory neuron it infects. So the pattern of basically infection or the site of infection is very specific to the nerve that is involved. So yes, this is basically an example of the herpes zoster. So very similar to what you see with your herpes simplex. These very big filled like fluid sacs that are literally will be popping over, crusting over, and you have this erythematosus base. So these are very clinical. Usually this is harmless. They usually resolve within a week or two. But the issue with herpes zoster or shingles. It's not that. It's this post-therapeutic neuralgia. This basically means that you have pain, and a pain that persists long after the rash has resolved. This pain, we call this a ghost pain. It's a pain that stays for years or almost all your life. And it can be extremely painful. So you're having pain constantly. This can be severely debilitating. So I know a lot of people that have had to stop their jobs and they have had to stay at home because it's very hard to treat this pain. Even if you take heroin or you take fentanyl, the strongest opioids, it's not going to help you. It's a very, very nasty type of pain. So it can be very, let's say, dangerous. So when it comes to the complication of varicella, so if we look at chickenpox, usually it's self-contained. But if you're an adult or a pregnant woman or you're immunocompromised and you're actually infected for the first time ever with chickenpox, then this can be an issue because now that virus can start going to your lungs, to literally your brain, to your other organs, and start doing quite a lot of damage. So it can be very life-threatening in some way. So you can have pneumonia in your literally brain. Can have actually something called cerebellar ataxia, which is literally the dying of your cerebellum, which is very dangerous. So varicella, if you're a kid and you have it, it's good because it's very mild. But if you're an adult or an immunocompromised person, and for the first time ever, you're basically infected with the herpes zoster virus, it can be deadly. The herpes zoster, as we know, basically later on when it gets reactivated, we know that you have these rashes or these kind of vesicles, these vesicle rashes that you get. But as we know, the most severe thing is this postherpetic neuralgia. This is the most, let's say, biggest complication. But in generally as well, if you're immunocompromised, also, other than having this postherpetic neuralgia, the virus is going to spread into other nerves and specifically your ocular nerve, which can actually cause the loss of vision. So it has other complications in general as well. So what we see with these people that are immunocompromised, the T cell response are extremely important in preventing the reactivation of a virus. So we really need T cells. And one thing that we also really encourage people, especially people that are older and 50, 55, because that's where usually their herpes, the zoster virus starts to reactivate to create shingles, we highly recommend to get a vaccine. So you take again the varicella vaccine, basically the chickenpox vaccine. Even though you took it as a child, they still recommend you to do it again to basically make your T cells stronger and make sure that the Zoster's virus is not going to go up again. So now moving on to another interesting virus, the Epstein-Barr virus. Epstein-Barr virus, we refer it as the kissing disease because it's usually transmitted through saliva. It EBV loves to infect B cells, specifically B lymphocytes and epithelial cells. And again, they love to establish lifelong latent infections. So usually EBV, we get it through basically, kind of saliva. So they always go through your oropharynx kind of cavities. So they infect your epithelial cells. They can establish latency there, but they usually love to go into B cells because they love to bind to the receptor CD21, which is found on your B cells. So once inside the B cell, it can basically go this lytic replication or establish latency. So the first time you get infected with it, you have basically the disease coming up, which is called infectious mononucleosis. Very common. Again, EBV is, I think 60 to 70% of the population is infected with EBV. It's very, very common. The first time you get infected, you have mononucleosis. It literally is similar to what you get in a cold. You have fever, a sore throat, lymphadenopathy. So lymphadenopathy is literally when your lymph nodes get swollen, and fatigueness. Again, very normal symptoms that you can confuse them with the common cold or in generally with the flu. So it's not the easiest to basically, in some sort of way, to kind of through just looking at the symptoms, know that this is mononucleosis. A hallmark of mononucleosis is atypical lymphocytes. What does that mean? So these are your T cells, very nice, well-rounded cells. Atypical lymphocytes means that your T cells have this very, very big and atypical morphology. They're not round, they're more, this guy looks like almost kind of a paw. So very different morphology. This happens because the EBV is binding to your B cells. It's infecting B cells. And this causes your T cells to go crazy. They start to really activate. And it's because of this activation that T cells start to go crazy and they start to grow really big that our lymph nodes start to actually grow because T cells are found in your lymph nodes quite often. So our lymph nodes start to grow because you have these very big T cells all over your lymph nodes around. And these, because the T cells are so activated, they can cause, in generally, fever and fatigueness. So usually the symptoms of mononucleosis are coming from your atypical lymphocytes. But then usually mononucleosis subsides. It might take 2 to 3 weeks. It can take, or even a month. It sometimes can take quite long, but it will subside. The issue with EBV is that its, let's say, recurrence or reactivation can induce cancer. It can actually make B cells start literally going into this kind of, let's say, uncontrolled proliferation. It stops apoptosis, it stops all the signaling mechanisms, and makes them just go crazy and replicate. And this is what you get for Burkitt's lymphoma. So it's a B cell malignancy. But again, EBV can also establish latency on epithelial cells. So you get to see your nasopharyngeal carcinoma and other types of cancers coming up. And you see this quite a lot in a lot of immunocompromised individuals because, again, you don't have your T cells that are controlling your EBV. So if you're immunocompromised and you have EBV, you need to be careful with cancers per se. Of course, EBV it's usually infected in humans, but we've seen it also infect um, other animals and actually causing them to go into in some sort of way cancer. So its oncogenic properties are quite broad when it comes to species. One thing about EBV is that, as we said, it loves to produce latency. When it's under latency, it's not producing a lot of viral proteins. The very little viral protein that it produces, these are viral proteins that are literally evading or causing your immune system to shut down. So that's why it's so successful at not being removed, because even during latency, it's able to stop your immune system from doing anything. So it's a very successful virus per se. Now going into cytomegaloviruses. So cytomegaloviruses, basically, as we know, it's a beta herpes viruses. It replicates everywhere. Very similar structure, linear double-stranded DNA genome, replicates in the nucleus. It's extremely common. CMV again is also found in 70 to 80% of individuals. It's a, let's say, usually it's harmless. CMV is very harmless unless you're immunocompromised or you're a newborn. So CMV infection, usually when you're infected with CMV, you do get usually, let's say 80% of the cases, you do not get actually any symptoms. Usually it's asymptomatic. But if you do get symptoms, they're very mild. They very actually are very similar to mononucleosis. So you actually have, in some sort of way, fever, fatigueness, and lymphadenopathy. But what's different between EBV and CMV is the severe sore throat. Severe sore throat happens only with the Epstein-Barr virus, not with CMV. But generally, throughout the CMV, it induces latency, our immune system is able to control it. It's able not to make it literally go crazy. However, If you're immunocompromised, CMV can go unchecked and start replicating like crazy. And again, CMV can infect almost every single type of cell. So that's why you can get symptoms going literally to encephalitis, retinitis, pneumonia, hepatitis, gastroenteritis, and even cause transplant rejections and on and on and on, because this virus is able to go everywhere. An issue is when, pregnant women are have CMV and a very active form of CMV that is able to be passed on to the baby. Because CMV within a baby can cause a lot of different types of issues. One of them is this microencephaly, in where your head circumference is quite smaller than the usual. And this can actually have a lot of issues when it comes to development. But of course, one thing that we see a lot is hearing loss. We see a lot of actually hearing loss from babies coming from CMV infections. So it's a quite significant portion of it actually. So it's a big public health concern. So, and generally, we need to basically be treating these let's say pregnant women usually with antiviral drugs to kind of reduce the amount of CMV in the blood to make sure that this is not going into the baby. So as I said, usually the latency of CMV can be in various cell types. This could be in your monocytes, your bone marrow progenitor cells, could be literally in your epithelial cells. They go everywhere. Reactivation usually occurs when your immune system is suppressed. So that's one thing per se. Now going into a different type of viruses, which are your papilloma viruses. So your papilloma viruses, these are basically non-enveloped DNA viruses. These have a circular double-stranded genome. Your papilloma viruses are the most common sexually transmitted infection. So extremely contagious. This only requires skin to skin contact. It's very easily contracted. And HPV, just like your other DNA viruses, they also create lesions in your basically skin. These could be warts, basically these kind of very annoying kind of structures, which I'll show you some pictures, or it can be tumors. What makes HPV give you either warts or malignant tumors depends on the type of HPV, because there are many different types. We call them low risk and high risk. Low risk ones are the ones that can cause warts. So, what are warts? These are basically HPV viruses that are able to infect your keratinocytes in your skin, and they make them basically divide uncontrollably, but to a certain degree. So it's benign. It's not, uncontrollable proliferation. It stops to a certain degree. And you have these literally thickened keratinocytes, which gives you these kind of weird like structures. So this virus really stimulates these keratinocytes to really keep on multiplying and going on top of each other, creating these structures. These are generally harmless. Nothing really happens with this per se. The issue, if you have a high risk HPV virus. These high risk HPV viruses, the different thing that basically makes them different between the low risk ones is purely that they have this E6 protein and E7 protein. So this E6 protein degrades P53 and E7 inactivates retinoblastoma. So P53 and retinoblastoma, these are your guardian angels in your cell. These are the ones that really will cause cells to go into apoptosis if they're cancerous or if they're infected with the virus. These high-risk HPV are able to stop it. So suddenly this cell lost the ability to go into apoptosis. Examples of these HPVs that actually have this, it's HPV 16 and 18. They really will stop retinoblastoma and P53 and make your cells grow uncontrollably to cause cancers. And the cancers can be basically, associated to the anus, to the oropharynx, to genital areas, to the cervix, you name it. Thankfully, because it's caused by a virus, we can actually create a vaccine against it. So now the current vaccines that are there for HPV usually have multiple types, basically target multiple types of HPV. So they target 90% of HPV strains that cause cervical cancer, anal cancer, and basically can cause also genital warts. So this is basically one of the cases where we're able to actually prevent cancer by reducing the amount of these DNA viruses, which is the human papillomavirus. So for the last virus that I'll quickly go through, your pox virus. And pox viruses, as we said, very unique, has this very weird kind of spiral or kind of complex shape. It's also weird because it's a DNA virus that replicates in the cytoplasm. Very weird for that, because usually DNA viruses are in generally in the nucleus. But today I'm just going to be talking about Molluscum contagiosum. So what is Molluscum contagiosum? It's a virus that usually gets also you're able to get infected through skin to skin contact, but also through contact of other humid, let's say, objects like a towel, for example. If the towel has the virus, you can actually contract it if you touch it. But thankfully, with Molluscum contagiosum, it's very harmless. You get only the presence of these papules. These are very different to what you see with your herpes viruses or in generally with your varicella zosters. They are flesh-like, very firm, and they have this indentation, this very dent, so this kind of opening. So hence why we call this umbilication, as if you remove the umbilical cord. But that's it. They're painless. They might get a bit inflamed or itchy, but that's it. Usually you get to see them on the face or trunk or extremities of children. Usually children are the most ones that get infected with this one. In adults, they can be found in your genital regions, meaning that they can be also sexually transmitted, because again, it's skin to skin contact. But again, they're very nothing really dangerous about them. The nice thing about again with Molluscum contagiosum, they do a lot of these basically inclusion bodies, but different to herpes viruses, the inclusion bodies are on the cytoplasm. They're not in the nucleus, and the Henderson, basically the inclusion bodies, we call them Henderson-Patterson bodies. They have this very distinctive characteristics or morphologies. So diagnostically, you can just remove a bit of the papule. So you literally remove a bit of this, look at the cells, and you see, oh, there's this Henderson bodies indicative of the pox virus, basically this Molluscum contagiosum virus. So transmission, as I said, it's usually skin-to-skin contact and also through contaminated objects like towels or clothing, but also can be transmitted sexually. So generally, the clinical course or treatment of molluscum, usually there's no clinical course, like there's no treatment. Usually you just wait for weeks or months or a year maybe for them to by themselves be removed. So sometimes people don't want to really wait for that long, so you can go and actually remove them cosmetically. So it's not a big issue per se. And generally, molluscum contagiosum is not dangerous, but if you keep getting a lot of molluscum contagiosum quite often, for us clinically, that's indicative that you have some sort of deficiency in your immune system. Because our immune system is very good at stopping it. Usually, okay, you have the first infection, and usually you do not have it anymore. But if you keep having molluscum contagiosum being coming up and up again and more than one time, it usually tells you that you're immunocompromised. Either you have HIV or AIDS, or you have a primary immunodeficiency or something. So usually for us, it's more of a clue. So that's how we look at these kind of pox viruses, or most specifically molluscum contagiosum. But guys, that's all for today. I know it's been a lot, it's a lot of viruses, but just to show you or kind of explain to you all these different viruses that we get infected with. And I have to say, if I'm looking at statistics wise, all of us here have one of these viruses. Statistically, it's basically indicative. So it's always nice to know your enemy per se. So, do you guys have any questions or any, let's say, basically anything that you want to discuss?
All is clear.
Okay, perfect. Well, if everything is good, guys, have an amazing weekend. I'll see you guys on Tuesdays. On Tuesday, and on Tuesday, we're going to talk with a different kind of type of viruses, most probably RNA viruses. So, other enemies. So, guys, have a nice weekend and see you later.
Thank you, doctor.